I'm delighted to introduce our speaker for today, Dr. Suzanne Lentzsch. I'm going to read a little bit, but I feel like I've gotten to know her via the Endocrine Society, where she just gave a beautiful talk, a symposium talk. And this morning, because she's very punctual, she arrived at 8 a.m., so we've had a half hour to chat. So Dr. Lentzsch is Professor of Medicine, Director of the Multiple Myeloma and Amyloidosis Service at New York Presbyterian Hospital, Columbia University. She received her degrees from Humboldt University in Berlin, and she told me probably the most interesting little fun fact is that she graduated in 1990, and that was in East Berlin, where she grew up, and she was on top of the wall when the wall came down, right? When Tom Brokaw was on the other side and she was on top of the wall. So that's very, very exciting. Completed her residency and fellowship at Humboldt University and a research fellowship studying the mechanism of thalidomide and its derivatives in multiple myeloma. And that was under the mentorship of Dr. Kenneth Anderson at the Dana-Farber Cancer Institute in Boston. And then she had published a paper on multiple myeloma and multiple myeloma bone disease and was at an American Society for Hematology meeting. And Dr. David Rudman, who was at the University of Pittsburgh, actually recruited her to come to the University of Pittsburgh. And that's where she was for some time until she was recruited in March 2012 to come to Columbia University. She does translational research that focuses on the identification of novel targets for the treatment of multiple myeloma, and specifically what interested me was multiple myeloma bone disease. So I thank her very, very much for coming here to visit us from up the street. We're looking forward to your talk. Thank you, Sister.
Thank you so much for the nice introduction. Alice told me already I have to shout a little bit with a bad acoustic in the room and my accent. So if you have any trouble understanding me, just let me know. Yeah, thank you. That was a very, I would say, nice introduction. Again, I want to emphasize that I worked with David Rudman for 8 years at the University of Pittsburgh. Many of you might know him. I would say he's the most famous man in multiple myeloma bone disease, and that time was really kind of put an imprint on my life. And we still have a very good relation. Unfortunately, our paths somehow kind of divided, and he's in Indiana, I'm in New York, but we still kind of I see him as my mentor and kind of like a father. The work I present today is a little bit a mixture on multiple myeloma in general. I think that at least our endocrinologists at Columbia are always interested in what are the special features of multiple myeloma bone disease, but also what is kind of the latest update in research. Here are my disclosures. And let's go and start. So with the introduction of novel drugs in multiple myeloma, especially the proteasome inhibitors and the immunomodulatory drugs like thalidomide, Revlimid, or pomalidomide, the survival in multiple myeloma has really increased significantly. You can see that here. That's a nice graph from Shashi Kumar from the Mayo Clinic, in which he analyzed over 2,000 patients for their outcome according to the time they were diagnosed. And you can see that patients diagnosed between 1971 and 1976 had a much poorer outcome than patients diagnosed after 2000, when we had Velcade available, for instance, but also thalidomide and Revlimid. But the problem what we have in multiple myeloma is still that most of the patients develop bone disease. Around 60% develop fractures when they have multiple myeloma, and which is 6 times higher than the expected fracture incidence. So this is based on certain features in multiple myeloma bone disease. First of all, we have in multiple myeloma pure-lytic lesions. So there's not a sclerotic component in multiple myeloma bone disease. The fact that we have pure-lytic lesion results also in the high risk of fractures, which is a hallmark of multiple myeloma. And what is typical, and what you can see here, that this is a multiple myeloma lesion. You see a dense infiltrate of plasma cells, and at the end, at the rim of the plasma cell infiltrate, osteoclast activated on top of the bone, most likely doing active bone resorption in this moment. And we know that there's a strong interaction between the multiple myeloma cells and the microenvironment such as osteoclast and osteoblast. And you probably know this, but just as a reminder, multiple myeloma cells secrete many tumor-derived osteoclast activating factors. I mentioned already, and we discussed that macrophage inflammatory protein, MIP1 alpha, for instance. This was how David Rootman and I were brought together. I've showed that MIP1 alpha comes from the myeloma cells, and he showed nicely that osteoclasts stimulated with MIP1 alpha undergo very active bone resorption. So there are many tumor-derived osteoclast activating factors that stimulate osteoclasts, but at the same time also osteoclasts have a positive feedback to the tumor cell. Myeloma cells also inhibit osteoblasts by several tumor-derived osteoblast inhibitory factors. We discussed already DKK, IL-3, frizzle protein, L7, but also it induces stroma cells to secrete rank ligand that further activate osteoclasts. So it's a vicious cycle of inhibition of osteoblasts and activation of osteoclasts resulting in pure lytic lesions. And that's a contrast to other tumors. For instance, prostate cancer, where you have a stimulation of the osteoblast, or breast cancer, where you have mixed sclerotic and lytic lesions. And this is also the fact, and I like that to show that especially for medical students. We don't have medical students here, but just to illustrate, why don't we use bone scintigraphy in multiple myeloma? So technetium, which you use in bone scintigraphy to detect metastasis, for instance, is kind of, goes into the osteoblast. So the osteoblasts take up the technetium, and if you have an inhibit osteoblast, you underrepresent in your scintigraphy the extent of lytic lesion or of bone disease. And you can see this devastating bone disease. This is almost the whole femur is gone. Huge lytic lesion, but at the same time, you can see that the bone scan is almost negative and really underrepresents. So never do scintigraphy in multiple myeloma. This is the reason. Again, I don't know if we have medical students here, but usually they say, aha, that's a nice explanation. So what do we do in terms of imaging bone disease in multiple myeloma? It sounds very easy, but I can tell you that among the experts, the International Myeloma Working Group, and I'm on the panel for imaging, there is a huge controversy. How do we image multiple myeloma bone disease? And let me start with a good old metastatic bone survey, the skeletal survey, which we still order for multiple myeloma. It is in the US still the gold standard, not in Europe. So it includes the whole skeleton, including the skull, vertebrae, pelvis, extremities. It sounds ridiculous when I mention this, but I came to Columbia and reading the first reports, or I would say the 10th report, I said, what about the femur and the humerus? So at Columbia, before I came, they didn't even include the femur and the humerus. So there are a lot of, I would say, mistakes you can do. It sounds kind of, very embarrassing, but that's what I figured out. So you have to make sure that your radiologist really orders kind of, all the bones. I know that Bart Barloghi, who is here at Mount Sinai for 2 years, 3 years, is even including the fingers and the toes in his skeletal survey. So there's some variation, but again, it's the gold standard to include the long bones, pelvis, vertebrae. The problem what we have as a skeletal survey is it's only in 80% and 80% of the patients who have lytic lesions. Why is this? It's relative insensitive in the pelvis and the vertebral spine, because you need to lose at least 30% of the trabecular bone before you see any lytic lesions. And you can imagine in the long bones, it's easy to see this loss, but in the vertebral spine, it's very difficult. So that's why in Europe, the skeletal survey is not used anymore. What they use for the detection of bone disease and multiple myeloma is a low-dose whole-body CT scan. Very elegant method. You do a CT scan with a low dose from head to toe. It can be done within 2 minutes. So usually I say kind of, it's 5 minutes. It's much more convenient for the myeloma patients because they just kind of, lay down and have their scans, and scans of in opposite and contrast to moving around, especially for patients with fractures or older patients, it can be a little bit cumbersome. It shows bone destruction much more kind of, earlier. It's more sensitive. But again, it is not available in the US. The reason for that is, you can imagine everybody can do a low-dose full-body CT scan. You don't need a contrast, you just need a CT scan. The reason is there is no code for insurance to order this. That's the only reason. So what do? The myeloma experts have some network, and we say, okay, this is what we use. We order a CT of the head, the chest, the pelvis, abdomen, and then we just bend the arm of our PET center or our radiology and say, please do the arms and the legs for free. So that's usually the deal, how we do a low-dose whole body CT scan. So we do it at Columbia. Our radiologist likes it much more than a PET CT, which is kind of the gold standard here in the US. Much more expensive, much more radiation, but radiology really hates it. They say, I don't know what to do if I have an SUV of 4. Is it relevant or not? What do we do in multiple myeloma patients with this? I cannot really comment on this. This is just a statement based on a lot of discussions with our PET center. But again, in the US, the gold standard, we think we are working on new guidelines to say we can do a PET CT, but it's not necessary. It's not really kind of necessary a whole dose low body CT scan, especially especially due to the fact that the low dose whole body CT scan has a radiation exposure similar to a skeletal survey. So that's one of the advantages. You don't want to do a PET CT every 6 months or even each year in a patient who has an MGUS or smoldering multiple myeloma. The radiation exposure over the years would be unacceptable. So that's why, again, PET CT, much more sensitive than a skeletal survey, but has some disadvantages. What do we do with the MRI? We found out that the MRI is very sensitive, especially in detecting lesions, plasma cell lesions in the bone. I'm not talking about lytic lesions, I'm talking about plasma cell lesions. You can see that here very nicely. And it is less sensitive when you would like to detect small lytic lesions. So it's a complementary method. And usually what we do in multiple myeloma, we start with a PET CT or with a low-dose whole-body CT scan and X-ray to detect lytic lesions. If this is negative, we do the next step and we do an MRI to see whether there are plasma cell infiltrates in the bone that let us know whether the patient has a high risk to develop later in this area lytic lesions. And we found out that if you have in the MRI more than one focal lesion, that your risk to develop a lytic lesion is around 60%, and that's why we included in the updated criteria for the diagnosis of multiple myeloma created by the International Myeloma Working Group in additional CREP criteria. That means you can make the diagnosis of multiple myeloma when you have one of the CREP criteria, hypercalcemia, anemia, renal failure, or bone lesions. But in addition, if you have more than one focal lesion by MRI, you can start treatment for multiple myeloma. So we expanded the criteria for the treatment of multiple myeloma based on MRI. So I talked a lot about bone disease and how do we image and how we detect this. How do we treat bone disease once we detected the bone disease? The most important treatment is still you eradicate the plasma cells. This is what really, the plasma cells is the fuel for the development of the lytic lesions. Once you have lytic lesions, and I don't want to talk about orthopedic intervention, vertebroplasty, kyphoplasty, analgesics, radiotherapy. One comment, 10 years ago, we were very excited about kyphoplasty and we did it on a lot of patients. We learned that the skeleton in multiple myeloma is in general very frail. It's not the one lytic lesion. It's a frail bone that fractures in one or the other vertebrae. So if you do kyphoplasty, you have a very stiff vertebral body. And the adjacent vertebral bodies are still frail. And we saw an increased, I would say, risk or an increased number of fractures above and below the, I would say, treated vertebral bodies. So I rarely do that. I think for the last 3 or 4 years, I hope no interventional radiologist is here. I didn't do that, so no kyphoplasty. But again, it's something you could really consider. Radiation is very powerful, but use it judiciously. A large radiation area in the pelvis will destroy a lot of bone marrow, and it really inhibits your future treatment options because patients might end up with thrombocytopenia or low neutrophils. osteoclast inhibition with bisphosphonate rank ligand inhibitors is still what we do for all our myeloma patients. That brings me to zoledronic acid and pamidronate. You know that we can use both treatments for multiple myeloma bone disease. They have the same potency in inhibition of skeletal related events. You can see that here very nicely. But I would like to point out a study that was done in the UK. And what they did was very interesting. They used a large number of multiple myeloma patients, around 2,000, and they compared zoledronic acid versus Clodronate, which is an oral bisphosphonate, not used in the United States, but in Europe. So that study was very important. And what they did is they treated all myeloma patients who needed treatment for multiple myeloma, regardless whether they had a lytic lesion or not, because the argument and the question is always, should we treat myeloma patients with bisphosphonates who do not have any lytic lesions? So again, patients were randomized into zoledronic acid or Clodronate. And what they showed with a relatively long follow-up was that zoledronic acid was much more potent in reducing the skeletal-related events in comparison to Clodronate. But interestingly, it also improved the progression-free survival and the overall survival. And that was unexpected and completely new. It was, over the time, not very impressive. It was years, it was 4 months actually, but that zoledronic acid has any effect on multiple myeloma was completely new for us. We saw the kind of, increase or much higher rate of ONJ, of the osteonecrosis of jaw, with zoledronic acid. So what I already pointed out was that they treated patients regardless whether they had bone lesions at the time they started treatment or whether patients had no lesions at baseline. That means start of treatment with zoledronic acid, Clodronate, or the chemotherapy for multiple myeloma. And what you see here is that regardless of the bone lesion, zoledronic acid significantly decreases the skeletal related events, here with bone lesions and here without bone lesions. So that highlights the importance of treating all patients regardless whether they have bone disease or not. And this is what we do. When I make the diagnosis of multiple myeloma and I say, okay, the patient requires or needs treatment, we start bisphosphonates at the same time we start our treatment for multiple myeloma. ONJ, I have to say it's an incidental finding. Patients usually do not have any symptoms like pain. They come to our clinic and say, I have a sharp feeling in my mouth. Can you check it out? So it's just exposed bone. Sometimes there is a secretion or you can have some bone pieces, that the patient feels. 10 years ago or 15 years ago, I saw it a lot, I have to say, with new knowledge that ONJ really is due to the increased frequency or prolonged treatment with bisphosphonates, and mainly due to the fact when you have infections in your teeth, we know much better how to handle this. So before I start bisphosphonates, I send patients to a dentist for dental clearance, which is always a struggle because patients like not to go to the dentist when they have multiple myeloma. And so I'm kind of delay the bisphosphonate treatment, which is not good for the multiple myeloma, but we do that really religiously. So, and very often we are surprised that there need to be a root canal or teeth need to be removed. But if you really do that before treatment with bisphosphonates, it helps a lot. We keep in mind that treatment with bisphosphonates for multiple myeloma can be over years. So it's not that we say, okay, I give you 3 times bisphosphonates and then you go to the dentist. No, I have to fix it before I start that long journey of the patient. So, but in order, there's a lot of discussion. There's a lot of discussion. How long should we give the bisphosphonates? How often? And we know that the ONJ occurs with prolonged treatment. So this is a study from Nupa Raja from the Dana-Farber, in which she said, okay, maybe we treat patients for 2 years with bisphosphonates monthly with Zomera, and then according to the NTX, we adjust the treatment. And what she did is that patients who were treated with bisphosphonates were treated according to their NTX level. Patients with a low NTX level, with a high NTX level, received zoledronic acid continuously every 4 weeks. Patients with a low NTX level spread the interval to every 12 weeks, until they had either skeletal-related events or progression of disease, or until the NTX went up again. And what they showed is that the less frequent dosing was feasible based on the NTX, and that the rate of skeletal-related events in the study was relatively low, with 6% in the first year and 4% in the second year. The ONJ risk in this prolonged patient population was 3%. So they showed that the spreading of the intervals of zoledronic acid is feasible, and that's what I usually do. I treat my patients for 1 year with bisphosphonates, and patients who are in a complete remission, that means have no further stimulation of the osteoclasts, either I stop the bisphosphonates or I spread the intervals. Why do we do this? Myeloma is not a curable disease, so I always have to think ahead. Once I have an ONJ in a patient, I cannot give any bisphosphonates, so I kind of prevent that treatment. So I really try to give a little bit of bisphosphonates to cool down the osteoclast, to have the option later to restart in case of a relapse. So what about the guidelines from the International Myeloma Working Group? So again, bisphosphonates should be initiated in patients as soon as they start anti-myeloma therapy. You can give zoledronic acid or Aridia. Usually I give zoledronic acid because Aridia is just too cumbersome. It's over 2 hours, a little bit longer treatment. I prefer Aridia or Pamidronate when I have patients with renal impairment. I think it's less toxic for the kidneys. We recommend zoledronic acid over any oral bisphosphonates. So in the US, I don't think that we give any oral bisphosphonates. And again, it is new that zoledronic acid has shown also some increased survival. I think that speaks for the fact that the osteoclast also can activate or stimulate multiple myeloma cells. You all know that in multiple myeloma, or when you have lytic lesion or stimulation of osteoclast, that there's an imbalance between OPG and rank ligand, that you have an excess of rank ligand that promotes the lytic activity of osteoclast. And you have much more experience with Denosumab, that's a monoclonal antibody against rank ligand, than I have in multiple myeloma, because Denosumab Xgeva was just recently approved for multiple myeloma. But I want to mention a study that compared zoledronic acid with Denosumab in a large number of patients, and they're, in terms of inhibiting skeletal-related events, equal. So there's much more hypercalcemia with Denosumab, and that's what we kind of see in multiple myeloma patients, especially with renal impairment, and we're a little bit afraid of this. And that was very disappointing. The same number of or percentage of patients with ONJ occur, and Denosumab is a novel treatment which is very elegant and easy for patients with multiple myeloma. You don't have to check the renal function, and you can give it subcutaneously. But I think there are also some issues with Denosumab. I learned that from our endocrinology group, that if you give Denosumab, you have an increased risk of fractures once you stop that. So you need to overlap with bisphosphonates, when you stop Denosumab. I think that scared us a little bit, the myeloma doctors, hearing those experiences. So I would say most of the myeloma physicians still stick to zoledronic acid, and we feel very comfortable with this. But again, rank ligand, Denosumab is a new option for us. With Denosumab? Yeah, also monthly. We give it once a month in multiple myeloma. I mentioned already that the multiple myeloma cell has a strong interaction with osteoclast, but also with osteoblast and with bone marrow stroma cells. And I would like to talk a little bit about, what is the interaction with other partners of the bone marrow microenvironment. And let me start with the osteoblast. So we don't know what is the mechanism of the prolonged osteoblast suppression. So we all know that you can go into a complete remission for many, many years, for 10 years. Once you have a lytic lesion, even smaller lytic lesion, usually do not heal. You have a sclerotic rim, sometimes you see this response, but the lytic lesions never go away. So it was especially David Rootman's group who said, why is that in long-term remissions, those lesions never heal? And why is that in vitro, when you have osteoblasts, that you have many, many passages of the osteoblast, they still have kind of impaired osteoblast differentiation, osteoblast from multiple myeloma cells. So there's a prolonged effect on the osteoblast, even if which is not explained by a direct interaction. And he focused a lot on binding partners for RUNX2. RUNX2 is kind of, you know that very well, very important for osteoblast differentiation. And they found in his group, found and showed very nicely that GFI, growth factor inhibitor 1, has multiple binding sites that's located on the RUNX2 promoter. And GFI1 is a transcriptional repressor that recruits histone-modifying enzymes. So GFI1 can modify also the chromatin structure, and they looked for the bone marrow microenvironment and found that in multiple myeloma cells, there's an increased expression of GFI1 in contrast to normal patients. What they did very elegantly is that they knocked down GFI1 and multiple myeloma cells, but also in normal patients, and you can see there's a high expression of GFI1. And when you knock it down in multiple myeloma patients, you can see that RUNX2 goes up, so that's a direct inhibition for GFI1 of RUNX2. And this is a little cartoon which David Rootman was so nicely to give me to show this. You can see the RUNX2 promoter, multiple myeloma cells induce GFI to bind to the RUNX promoter, and that subsequently leads to the attraction of histone-modifying enzymes with epigenetic modification that probably lasts much longer than just the direct myeloma osteoblast interaction. It explains why you have those long-term inhibitory effects on the osteoblast induced by multiple myeloma. Osteocytes, we never really talked about osteocytes, but it's more and more in the focus of research in multiple myeloma. So we know that osteocytes have a bidirectional signaling, notch signaling with multiple myeloma cells. So what happens if they come in contact and induce notch signaling, that there's a proliferation of multiple myeloma cells, but the notch signaling induces apoptosis in osteocytes. Apoptosis in osteocytes attracts osteoclasts or recruits osteoclasts for bone resorption. I think that's a logical mechanism, but in multiple myeloma, you can imagine more lytic lesions. But at the same time, the osteocytes secrete sclerostin. The gene for this is ZOST, excretes sclerostin, and sclerostin inhibits Wnt signaling, which is very important for osteoblast function. And this was shown by Dr. Eder and GBMR in 2016. They looked for sclerostin treated, and they found that healthy individuals have high activated beta-catenin. I mentioned already, beta-catenin is important for Wnt signaling. In multiple myeloma cells, the Wnt signaling is inhibited, and when multiple myeloma is treated with a sclerostin antibody, the Wnt signaling the beta-catenin and Wnt signaling reoccurs, suggesting that sclerostin really interferes with Wnt signaling that is critical for osteoblast development. Sclerostin, it was shown again, that's Nupal Raj's group, is highly expressed in multiple myeloma, much significantly higher than in other tumors on healthy individuals. So it's highly expressed in the blood plasma, but also in the bone marrow plasma. And this is a work again from David Rootman. He looked for sclerostin antibody. So he induced this multiple myeloma cells, 5-TGM, injected into the tibia of mice. You can see that here. Bone lesions, you can see nicely the lytic lesions here, but when he treated the mice in which he induced the tumor with sclerostin antibody, he could completely abrogate the development of lytic lesions. Very nicely shown. Also, if you see the sclerostin knockout mice, you prevent or you protect the development of lytic lesions when you induce or when you implant multiple myeloma cells into those mice who have a knockout of sclerostin. So in summary, it's an osteocyte-secreted protein. It inhibits osteoblast-mediated bone formations via the Wnt signaling. I mentioned that already. It's an attractive mechanism of action, especially if you knock down sclerostin in certain tissues, for instance, in the skeletal tissue, because you limit really the off-targets effect. What about osteoclasts? I still have to talk about osteoclasts. So I think that it's still the most attractive mechanism in multiple myeloma for inhibition. So activin is a protein that was shown recently. It binds to activin receptor type 2A on osteoclast, but also on osteoblast. Then activin stimulates the activin receptor. It increases osteoclast activation, but at the same time inhibits osteoblast. So it was shown by Nuparaj's group from the Dana-Farber that activin is highly expressed in multiple myeloma patients, especially when they have more than one lytic lesion, in comparison to patients with very limited lytic lesions or patients or non-multiple myeloma patients. It mainly comes from the osteoclast and from the bone marrow stroma from the microenvironment. And subsequently, an antibody was developed, sotatercept, a decoy receptor that neutralizes activin A. And this again is a mouse study. Myeloma cells were injected into the femur of the mice, and when treated with the receptor neutralizing activin A, you can see that the inhibition of the development of lytic lesions was significant. Based on this, Dr. Raj started a phase 1 multicenter trial using sotatercept in patients with refractory multiple myeloma. I can only show you the latest updates from ASH 2015. The trial is still ongoing, and we hope to get some data this year. What about other targets for osteoclast and multiple myeloma bone disease? And here I would like to show you some work we did in our laboratory. So in an effort to look for other osteoclast activating factor, we did very simple a multi-kind cytokine array to see what is expressed by multiple myeloma cells that could activate osteoclast. I know there are a lot of cytokines already known, but research so far has shown that none of the cytokines really are critical for the development of lytic lesions. So we did really a broad search for any cytokine secreted by myeloma cells, and we found that, and that was a surprise, that MMP13 is highly secreted by, by multiple myeloma cells. You can see here almost all metalloproteinases are secreted, but MMP13 up to 20,000 picogram per milliliter. That was really a surprise, and we started to look, what is the role of MMP13 in multiple myeloma? Just to recall, MMP13 is a zinc-dependent endopeptidase. It's an enzyme, and we know that metalloproteinases degrade extracellular matrix. We know that for tumor invasion, development of metastasis, but we also found that mice lacking of MMP13 show osteopetrosis, and that was very interesting. And you can see here, this is a mice with MMP13 knockout mice. You see that there is a much higher bone density in comparison to the wild type. We also found that MMP13 is highly expressed in osteolytic tumors and breast cancer, and that in giant cell tumors of young adults who are usually characterized by pure lytic lesions due to giant osteoclast also express MMP13 in high levels, and that's usually the accepted mechanism why those patients have lytic lesions. So that was very interesting, and we said, nobody ever talked about MMP13. It's inducing lytic lesions, even other lytic lesions and other tumors. So do our patients secrete MMP13? And this is a bone marrow. You can see a dense infiltration of plasma cells, and immunohistochemistry indeed was positive for MMP13. And we checked the serum of patients with MMP13 and found that patients with extensive bone disease had much higher levels of MMP13 in contrast to healthy donors and multiple myeloma patients without MMP13. This, by the way, reflects the MMP13 level of my laboratory. So more or less voluntary, everybody had to give blood that we could see what are the MMP13 levels. It was difficult for us because there are no normal or abnormal levels. We could only say, is it detectable or not detectable? We're still struggling with that issue, but we could at least show on a high number of patients that they're detectable elevated levels. So what we did next, we did very simple osteoclast formation assays. Osteoclasts from patients or from mice stimulated with vancomycin and MCSF, and we added MMP13, and what we observed was really a surprise. We saw giant osteoclasts, really large osteoclasts with an increased number of nuclei, and you can see that nicely. It's a dose-dependent increase of the osteoclast size and the nuclei number, we didn't see that the number of osteoclasts per se increased, just larger size and more nuclei. We also did bone resorption assays on dentin slices. You can see that the pit formation, so the bone resorption, was much higher and also significantly higher when we added MMP13 to those assays. And we looked for other MMPs. We said maybe that's a general features of metalloproteinases that they induce osteoclast fusion and you have those large osteoclasts. And you can see here that it is only MMP13, so it seems to be specific, that increases the osteoclast size and also the nuclei number per osteoclast. All the other MMPs had no effect on the osteoclast. Next, we did a co-culture. So we co-cultured osteoclasts and multiple myeloma cells in transfer assays without direct contact. And what we did is we knocked down MMP13 in the multiple myeloma cells. And this is the lower well with just the medium. Then we added to the upper well myeloma cells, 5-TGM myeloma cells. You see that there's an increased osteoclast formation, larger osteoclast. When we used knockdown MMP13 myeloma cells, they are much smaller osteoclasts. And when we added MMP13, we could rescue the size of the osteoclast. You see large osteoclast formation. This again is our analysis. Myeloma cell co-culture, large cells with high nuclei number, knockdown of MMP13 in the myeloma cells, decreased size and nuclei number, which can be rescued by the addition of MMP13. So the next natural step was to go into our mouse model. And in our mouse model, we use mice and inject 5-TGM multiple myeloma mouse cells directly into the tibia. And after 3 weeks, you have almost pretty much complete destruction of the tibia. And what you can see here in our positive model, indeed, there was the almost complete destruction of the tibia. On the right side, you see the data analysis by micro-QCT. But when we knocked down MMP13, we could completely, not completely, but almost kind of, almost completely rescue the development of lytic lesions, also shown here in the analysis by micro-QCT. This is the immunohistochemistry. You see here our mice, the tibia injected with PBS. Here is the mice injected with our mice myeloma cell lines, complete destruction of the microarchitecture. You see a dense infiltrate of myeloma cells. You see the lacunae or the bone resorption with large osteoclasts. That's a trap staining. But again, when we knock down MMP13, we have a much more maintained structure of the bone, less infiltrate, and you see the osteoclasts are much smaller. So having said this, the next question was, how does it come that can you use, if MMP13 is so critical for the development of lytic lesion, what about you use MMP13 inhibitors? MMP13 is an enzyme, and there are MMP13 inhibitors on the market. They were also tested in clinical trials for rheumatoid arthritis, so that would be perfect. We would just use a drug that was already tested in clinical trials and use it for multiple myeloma bone disease. But for that purpose, we needed to know whether the enzymatic activity is really critical. And what we did is we generated an MMP13 enzymatic dead mutant by a point mutation in the catalytic domain of MMP13. And that mutant is E223A. And what we did is we did, again, our osteoclast formation assays. We added the wild type MMP13 or the mutant, the enzymatically dead MMP13. What you see is, unfortunately, and that was very disappointing, you don't need the enzymatic activity of MMP13 to induce the osteoclast fusion. Independent of the enzymatic activity, you can see that the osteoclasts are very large when you add this, but also the nuclei number is elevated. So our dream from using just an MMP13 inhibitor was over, and we have to move on probably with neutralizing antibodies. We also looked for bone resorption. We saw the same, that the mutant of MMP13 could also induce bone resorption. And we looked further for mechanistic studies. How is that induced in the cells? How do we have the enlarged osteoclast? And this is also work in progress. But what we did first was some signaling studies. We know that pERK is critical for osteoclast fusion, and that pERK induces NFET-C, that's a transcription factor that further stimulates DC-STEM, which is a fusion protein for osteoclast. And you can see that the stimulation or that the addition of MMP13 wild type upregulated pERK, also induced NFET-C and DC-STEM. And we saw that with a wild type MMP13, but also with a mutational MMP13. When we added a pERK inhibitor, the UO126, we could abrogate this effect, and we also could abrogate the effect of MMP13 on osteoclast formation, suggesting that pERK or that MMP13 stimulates pERK as probably one of the factors that later leads to induction of NFET-C and DC-STEM. That brings me already to my summary slide. So we know that MMP13 is highly expressed in multiple myeloma, and interestingly, it's not expressed in all multiple myeloma cells. So we could, testing all our cell lines, we found some myeloma cell lines with extremely high levels, other with almost normal levels. Maybe that's also reflecting the fact that not all multiple myeloma patients really develop bone disease. We have patients with kind of really extreme and extensive bone disease already presenting. Other patients never develop bone disease. So maybe that might be an interesting finding to see for a correlation. So we found, and I didn't present data on this, that MMP13 is upregulated by multiple myeloma cells, especially when they interact with bone marrow stroma cells. And the reason for this is the secretion of IL-6 stimulates C-FOS, C-JUN, upregulates AP1 with the secretion of MMP13. MMP13 induces pERK, stimulates pERK, leading to upregulation of NFET-C with an induction of osteoclast fusion based on the upregulation of DC-STEM and increased osteoclast activation. For the future, and I mentioned that already, we focus on two things. Our laboratory, we would like to develop neutralizing antibodies against MMP13, and we also would like to have further information, what is a direct binding partner of MMP13 on the surface of osteoclast. We have some preliminary data. Interestingly, PD1H, it's a PD1 homologue, is probably one of the binding partners for MMP13. That brings the other kind of interesting topic, interaction between multiple myeloma bone disease and the immune system. That's a new area which a lot of researchers, especially Dr. Dodapkar from Yale now at Atlanta, are focusing on. So that's our future research. So in summary and in conclusion, I showed you that in multiple myeloma, we use zoledronic acid and denosumab for multiple myeloma bone disease, more zoledronic acid so far, but denosumab is a good alternative. I hope nobody from Amgen is in the room. They won't like it. We see improved and more flexible scheduling with zoledronic acid. It's not that like 10 years ago where we treated each myeloma patients every month until disease progression with zoledronic acid. We give it more in a, I would say, sense that patients who are in a complete remission, we stretch the intervals, or sometimes we even stop bisphosphonate treatment. I showed you a new role of osteoblasts and osteocytes, and I think we have some new approaches. It's still very, very preliminary, but maybe sclerostin is a new potential target for myeloma bone disease. Activin, I showed you this. I mentioned MMP13 antibodies, and last but not least, that's our team at Columbia. Again, I mentioned already David Rootman. He's my mentor. I always have to thank him. Stephen Weiss from Michigan, who helped me a lot with the MMP13 project. And in case there are any questions, I think I'm on time.